Hi, everyone. Thank you for joining our webinar this morning and afternoon. We're just going to give everyone a few minutes to join and then we'll get started. Okay, great. Thank you all again for joining our fifth Gradian Critical Care webinar. This one is on pain management in the intensive care unit. We will be going through slides with our various presenters and our moderator, and we'll be taking questions and answers at the end. As always, if you have any questions during the webinar, please use the Q&A feature to ask us. You're also able to chat with us and chat with me and the presenters if you have any technical difficulties during the webinar. The webinar again will be recorded. You might have gotten a notification in the beginning of the webinar, and you will receive a copy of the recording following the webinar as well. And then in addition to that, all of our recordings for the webinars will live on our website at gradienhealth.org under our training page. And then we would love to hear from you if you have any feedback or any questions, any ideas for upcoming webinars as well. Please reach out to customers@gradienthealth.org, and we'll be sharing that email again at the end of the webinar as well. Just a quick declaration of conflict of interest on the presenters and the moderators that you'll see here on your screen. And then I will turn it over to our moderator to get us started and introduce our panelists as well.
Thank you, Maria. My name is Ansbeth Ndebea, based in Tanzania, anesthesiologist. I'll be moderating this session, which is one of the important aspects in critical care. That we all know, most of the time when we see a patient in ICU, or despite how critically ill they are, but also if they are in pain, pain has to be managed. So in this webinar, will be with Dr. Anna from KSMC, anesthesiologist, but also be with Dr. Saleh Mrutu, anesthesiologist from Embed. Without taking much time, I would like to welcome Dr. Anna to start with the first part of the presentation. Thank you very much.
So, good evening, everyone. My name is Anna John Doho, as Sweetpat has introduced, and I'll take you through the first part of this presentation. So the overview of this presentation is as follows, as we will see about the introduction, what is pain, why should we treat pain in the ICU, and pain treatment approach, the RAT approach, what medication options do we have, and what are the challenges we face to manage the pain. And lastly, we'll see on the take-home messages. And we have objectives towards this presentation. And at the end of this session, all the participants will be able to understand the importance of pain management in ICU, and they will be able to describe the causes and sources of pain in critically ill patients, and they will be able to describe the assessment of pain in critically ill patients, and they should be able to outline pain treatment options that are present in critically ill patients. They'll be able to discuss the effects of uncontrolled pain in the ICU patients. They should be able to outline the challenges in pain management, and lastly, the participants should be able to implement recommendations to improve pain management in critically ill patients. Next slide. To start with the introduction, pain in critically ill patient is underestimated, and this is due to a number of reasons, and one of the most important reasons being inability to communicate between the patients and the healthcare providers. And pain management for critically ill patients need to be individualized, basing on the patient's primary pathology and the current conditions that they are presenting with. And this is to focus on the different categories of patients that we have in ICU. So most of the patients in ICUs, some of them cannot really verbalize, but some can verbalize and can follow commands, while some cannot verbalize, but at least they can follow commands. So managing the pain should focus on the category of the patient we have. We also need to understand that despite how we have different strategies in managing pain, but yet pain in critically ill patient is inadequately managed. And inadequately managed pain has consequences even after being discharged from the ICUs. So with the number of studies that have been done, there have been reported that about 50% of patients who have been admitted or have been nursed in intensive care unit, majority of them present with moderate to severe pain. And if pain is left untreated, then it causes dysfunctions in varieties of systems in the patient's And one of the important system dysfunction is pulmonary cardiac dysfunction and musculoskeletal dysfunction, gastrointestinal dysfunctions, which may lead to sympathetic overdrive, which leads to also suppressions of the immune system, leading to presence or poisoning of the patients towards infections. And on top of that, if pain is left untreated, it will be hard to wean off the patients from mechanical ventilations. So it is good to treat pain adequately so that we can have a better treatment outcome among these patients and also improve their quality of life and their well-being after hospitalizations. Next slide, please. So we have a triad here in this slide. There is an interaction between pain, delirium, and agitation. These phenomena are interrelated specifically in patients who are critically ill. Pain, as we can see, may be the primary source of, may be a primary cause of delirium and agitations, whereas agitations and delirium may have other causes, but because these patients have pain, there is precipitations of delirium and agitation, which also worsens the pain and also alters the response of pain towards the medication that are being used to patients. And now I would like you guys to focus on the varieties or the number of reasons or the causes that predispose patients to pain in intensive care. We have daily routine care in ICU. We have invasive and non-invasive procedures that are ongoing daily in ICUs, like turning, 2-hourly turning to avoid bed sores, physiotherapy, in endotracheal intubations, the suction of the endotracheal tubes, procedures such as inserting the IV lines and then taking samples for investigations. And again, the pathology itself, such as trauma, pressure areas, and also a new environment that the patient is taken into the ICU are the primary cause of pain, and this pain need to be managed. Next slide. So what is pain? So pain has been defined by an International Association for the Study of Pain as an unpleasant sensory and emotional experience that is associated with actual or potential tissue damage or described in terms of such damage. This means that pain is subjective and it is multi-dimensional in nature. The cause of pain is not always visible, and it is important for us to know that there is no balance, and noting or taking the unpleasantness and the emotions are the important factors to consider while managing pain. Next. So why should we manage pain in the intensive care unit? Why do we care about pain? So there is an evidence that says access to pain treatment is a human right. And this is the article which was done in 2010 by Lohman and his colleague, explaining on pain-free being as a human right. And it has a lot of things explained in this article, mainly on the patient's outcome who are in ICU. So I hope after this presentation, every one of us will go and look into this article to gain more on how to access the pain to treatment and why is it considered as a human right. Next. So if access to pain treatment is considered as a human right, how can we make pain free in our patients? What do we have to do? We have to manage pain. And then how do we manage pain? We have approach to pain management as RAT. So RAT stands for recognize. Then we need to recognize pain. if the patient is having pain. If yes, then we need to assess the severity of that particular pain. And then if we know the severity of pain, whether it's mild, moderate, or severe, then it's easy for us to treat that particular severity of pain to that particular patient. Next. So how do we recognize pain? If you look at the picture that is shown here in this slide, this is typically an ICU setting where we have varieties of things. There are monitors, the cardiac monitor, the ventilators, the endotracheal tube that is in, the patient is intubated. We have infusion pumps. We have different catheters and tubings. And this is a new environment to a patient, being one of a factor that affect pain in intensive care patients. We need to ask ourselves and ask the patients. Ask the patients who can verbalize and who can self-report their pain. If they cannot communicate, then we need to look at them. Are they frowning? And see if they are moving easily, and if there are any physiological parameter that is changing, such as checking the heart rate, the blood pressures, and also if patients are sweating. Then we need to ask people who are around the patient if they are aware if the patient has pain, and if there is one of the family member who knows whether the patient has pain, because a number of family members can also report whether their patient has pain or not, if they have this close relationship of communicating between them. Next. So the second mnemonic from RAT is assess. As I said, I would say assessment of the pain is a crucial and a critical part in pain management. This is because if you assess pain effectively and got a correct pain severity, then it is easy to give a proper and the best medication depending on the severity of the pain. So if every one of us must see this picture, see this patient is intubated, but he is comfortable, wearing glasses and relaxed, and now even reporting, describing his pain severity. So this is the ideal setting where we want to reach and manage pain and make patient comfortable. Next. So how do we assess? What tool do we use? So proper pain assessment tool depends on the category of patients that we have. So if we have non-verbal patients, then we have other tools that is responsible for their pain assessment, whether and again, if the patient is can communicate verbally and can follow command, we say the accurate assessment tool is the self-report of the pain severity. Now we need to know and remember that assessment of pain severity can guide the effectiveness of our therapy. Next. So here are a number of tools. We have numerical, visual, and again, you can have verbal. As I said, this depends on the categories of patients we have in our intensive care unit. The next. For those patients who are non-verbal and they are sedated, they cannot communicate, we have two tools where we assess the behavior of the patients. So we have behavioral pain scale, plus or minus physiological parameters, that is heart rate and arterial blood pressures. So with the behavioral pain scales, it has 12 points. If you can see, we have the behavior that we need to assess. And at the right side, we have numbers that's showing the score. So if we get a score of 3 to 12, Then 3 stands for no pain, and any score of 4 to 6, that is mild pain, and 7 to 9, that is moderate, and again 10 to 12 score enhance severe pain in our patients. And then after assessing the severity and scoring, depending on the behavior, we need to properly manage the pain. Next. This is another tool. This is a critical care pain observation tool. And it also has 4 parameters, but it has a score of 8 points. But the significant point is any score of more than 2, that signifies that the patient has pain. So the only difference between behavioral pain scale and critical care pain observation tool is that with critical care observation, pain observation tool, it can be used to both patients, whether it's verbal or non-verbal, because it can be used by healthcare practitioner. Next. If we can all remember the triad of pain, delirium, and agitation, they are the factors that influence pain response, as I explained before. So pain itself precipitates the anxiety and agitations, which can also worsen the pain severity. So it is good to remember and address all these factors individually rather than taking just part of sedations for analgesia. So it's good if we all know we have agitation for other reasons, we have delirium for other reasons, but again, we don't have to forget the concept of pain in critically ill patients, because we all know it is difficult because of the reasons I've mentioned before. And reaching here, this marks the end of the first part of my presentation, and I would like to hand over this to moderator to welcome the second presenter. Thank you.
Hello? Can you hear me?
Hello. Sweetheart, I can hear you.
Thank you very much. Thank you very much, Anna, for such a wonderful presentation and highlight of introduction, recognition, and assessing pain. So I will welcome the second presenter, Dr. Saleh, to take us through the second part. Welcome, Dr. Saleh.
Hello.
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 Hi, we can hear
Hello.
you.
Okay. Good evening, everyone. Like Dr. Ansbet introduced me, my name is Salehe. I'm a doctor working at Muhimbili in Dar es Salaam, Tanzania. So I will take you through the remaining part of our presentation, which entails on the treatment of pain in ICU. So before we dive into the actual management plan, I would like us to remind ourselves on why is it important to treat pain in this patient in the ICU. Dr. Anna did a very wonderful job, pointed out all the aspects that is in why are we treating pain in the ICU. One thing that she pointed out is that there are negative physiological and psychological consequences of pain. So it's important to treat our patients in order to prevent these negative consequences, which pointed out things like increased sympathetic drive, which prevents cardiac cardiovascular stability, vasoconstriction, diaphragmatic stability, exercise, increased oxygen consumption. So, it is important that treating pain is a humane thing to do. It's one of the human rights. So we treat pain in order to make sure we do a human thing to our patients. But also the effect we need to treat pain in order to be able to perform our daily medical intervention with ease, like mechanical ventilation, dressing the patient, insertion or removal of chest tubes, insertion of lines, etc. But also we have adverse event that might be associated with untreated pain. So that's why things like disruption of sleep pattern, prolonged hospital stay, anxiety, delirium, agitations, and post-traumatic stress disorders can be associated as an adverse outcome if the pain remains untreated. So with all that in mind, let's start with the options that we can go on how to treat pain in ICU. So you'll all agree with me like that pain has a certain pathway. You have an origin or peripheral area where there's nociceptive nerve endings that they will pick up pain, and you have the nerve conduction that will send them to the spinal cord, and then from the spinal cord they'll go to the brain where they will be interpreted, and also the brain they will send some modulating impulses in order to control the amount of pain that's going to the brain, or even the spinal cord can modulate. And with this picture here, you can see different drugs acting at different points of pain pathway. This brings about the concept of multimodal analgesia, using more than one drug with a different mechanism of action, acting on different places in order to combat pain, the intensity and severity of pain. With doing so, you minimize the need of opioid use, you minimize the amount of opioid use, and then you have adequate pain management with minimal side effect associated with individual drug. So with that, we have opioids, we have non-opioid analgesia and adjuvant. You have regional techniques as well for management of pain. So this is a good picture when you talk about the multimodal management of pain, targeting pain at different points while minimize the effect of opioid side effect associated with individual drug, and then maximize the efficacies by additive effect or synergistic effect of different medication of pain. Next, Mariam. So with that being said, there are different ways we can give analgesia in normal patients, and we all know about that. But in ICU, the most preferred route for analgesia is intravenous. And this is because when we come to subcutaneous intramuscular route or even oral, with critically ill patient, we are not sure how much of the drug can reach the system. That's when we're talking about the bioavailability of a drug. So the only way that we can ensure what we are giving it's reached the systemic circulation in these critically ill patients, it's IV. However, there are other patients that you can give oral, you can give IM, and this is dependent on the characteristics of your patient you have. But for those critically ill patients, hemodynamically unstable patient with severe peripheral edemas, your subcutaneous and your intramuscular will not be a good option for you because the bioavailability of drug will be reduced. And then with IVs, we have different modalities. It can be patient control, means you have a patient who control the amount and when the drug should be delivered to the system, depend on how he or she's experience pain. And we have nest controlled analgesia as well, and then you have the regional block. However, this the nest controlled analgesia, it's a mostly well known in our settings. So mostly in our setup, we rely on care provider to provide analgesia for a patient. The patient control analgesia is not well established in our settings yet. So this comes to the fact that the first presenter highlighted that in order to know your patient is in pain, so the proactive of healthcare providers to assess for pain and then to intervene. So the nurse controlled analgesia is the most widely performed in our setting. So our healthcare provider, us, we should be proactive in assessing the pain for our patients, giving the medication whenever required, at the clock and on demand while managing pain in ICU. Next. So now we have already see what our options in the route. Now, how do we choose? So opioids has been widely used in ICU because it offers 2 or 3 things. One, you have multiple routes that you can give with opioids while you are managing pain, but also with opioids, it has a sedative and anxiolytic properties, which we also desired for some of the ICU patients. Not all the patients in the ICU will need anxiolytic or sedatives, but there are some of the patients that will benefit for opioid because of its mild sedative and anxiolytic if it's required. But there are a number of patients who might not need opioids while they are in the ICU, and this has come the concept of WHO pain ladder for management of pain. So with going back to the assessment of pain, after assessing your patient pain, you need to classify the pain. If this patient has severe pain, if this patient has mild pain or moderate pain. And then after that, you come to the WHO ladder that if it's mild pain, we know you usually manage with non-opioid. Moderate pain, you give weak opioid with a non-opioid. And then when you come to severe pain, you give the strong opioid. But also there is an option for interventional pain management, which is the concept of regional analgesia for spinal, epidural, and then for those pain who they require surgery, so operation can be a way forward to remove pain, and then the patient will recover from that. Next. So the first group of the medications. So the first group of the medications they are opioids. So morphine, it's one of the commonly. So this is the opium plant. We all know it. So let's go to morphine, Mariam. So morphine is one of the commonly used analgesia in terms of opioid. So it's usually for user management of severe pain in combination with other adjunct medication. The half-life is around 1.5 to 2 hours when they're given IV, and the dose IV bolus is 2 milligrams. Then you can give 1 to 2 milligrams every 10 to 15 minutes. And then you assess the patient until you get the pain satisfaction. It's below moderate to mild. So you need to give repeated dose until you have achieved your analgesic requirement. However, there's an option for continuous IV for those people who have infusion pumps where they can hook up the morphine in the infusion pump. You give a bolus of 2 to 5 milligrams, or if you want to give at 0.05 milligram per kilo, or you can give 2 to 5 a loading dose, and then an hourly dose of 1 milligram. The issue with morphine has a metabolite, which the metabolite tend to be more potent than the parent drug. And this because the morphine is usually excreted through the renal after liver metabolism, they can tend to accumulate in those patients with renal failure. And this is, we know most of, not all, but some of our ICU patients, they can have renal impairment. So make sure your renal profile is good, or you can have a renal adjusted dose while you are dealing with this patient. And then the common side effect for opioid, you should be watchful for nausea, sedation, and respiratory depression. This comes for the patient who are already extubated, who are not in mechanical ventilation, so they can go to respiratory depression, and then you can have episodes of hypoxia with morphine as any other opioid. Next. So morphine is it's a natural occurring. So we have a synthetic version, which is a fentanyl. It's more potent than than morphine, and this is because it's more lipid soluble compared to morphine. So the good thing about fentanyl, it has little or minimal myocardial effect. So you can use for a hemodynamically unstable patient. And the issue of histamine release, which we're seeing with morphine, it's not there with fentanyl. So the incidence of allergic reaction is not there. The IV dose is 25 to 100 microgram boluses, 1 to 2 minutes, and then you can repeat every 10 to 15 minutes. But if you have your infusion, you can give a loading dose up to 200 microgram, and then you can maintain a 25 to 50 microgram of fentanyl. So there's for when you're giving the infusion, something to note is the fentanyl has a funny thing. Like if you give in a continuous infusion for a prolonged period of time, the half-life of fentanyl usually increase from 30 to 60 minutes, and then they go to up to 9 to 16 hours of half-life. So you should be very cognizant when you're giving, especially a prolonged infusion dose of fentanyls. So for patch, fentanyl is available for chronic pain patients. So this would not be very good for patients who are admitted in the ICU, who are hypotensive with regional hypoperfusion and edema, like we already discussed in the previous slide. Next. So another, you can say a more better version of an opioid, it's ramifentanil. It's very nice compared to the previous ones because this is usually fast acting and usually has a very fast offset as well. So it's 200 times more potent than morphine. That means 100 more times than fentanyl. Does not depend on liver for metabolism. It's very good for analgesia-based sedation, which is more, now it's a recommendation that if you want to go for sedation for ICU patient, it's more of analgesia-based sedation. So it's very good for mechanical ventilated patient. And if you're a patient, for those patients with a neurological condition that you need to do frequent neurological assessment because of quick onset and offset, sort of ramifentanil is your guy. It can give you that within a short period of time, the patient can be fully awake and then undergo your neurological examination if you want. So you can give a high dose of ramifentanil and get away with it because there's no issue of accumulation, and also with quick recovery, so you can give the high dose and still get away with it. The infusion dose is 6 to 9 microgram per kilo per hour, and then you can titrate depending on how your patient respond. But there are some incidents of hypotension and bradycardia associated with ramifentanil. All in all, ramifentanil is a better version of other opioids with morphine and fentanyl. However, it's not readily available in our setting, but it's something good to know and worth noting it. If you have ability to procure it in your situation, it's a very good drug. Pethidine, it's one of the commonest opioid in our setting. I don't know Zambia, how the situation is, but pethidine is more readily available compared to any other opioid. So the issue with pethidine, it's not very good when it comes to ICU patients because they usually rely on the liver for metabolism and then renal for excretion. And its half-life is very long, up to 15 to 20 hours. So now ICU patient, you have an ICU patient who has unassuring liver function, compromised the renal, and then it has a metabolite with normeperidine, which usually cannot reverse with naloxone. When it accumulates for a very long period of time, because it depends on the renal and the liver, so this patient has damaged liver and reassuring renal function, so they tend to accumulate, and when they accumulate, they'll bring issues of seizures, hallucination, and delirium. So use, but with caution. So we advise to use with caution, but when you go to other settings, like in developed world, the pethidine is not even there in the list of opioid that they are available in the ICU. Even in the guideline for pain management, it's not there. So, but in our setup, we use it. So we use it with caution, with have in mind that they can accumulate, especially you have a hemodynamically unstable patient. But for post-op patients who are just there in the ICU for post-op purposes, so you can use pethidine because you know their renal, their liver, it's okay. But you have a septic patient with all those multi-system compromise, pethidine can be a very challenging drug to use. Tramadol, so it's also readily available in our settings. So this is usually a centrally acting opioid-like, usually bind to the mu receptors and also has an inhibition of adrenaline and serotonin uptake. So it has the same common adverse event effect like any other opioid of nausea, drowsiness, vomiting, and headache. So it has less cardio and respiratory depression with a dose of 100 milligrams start, and then you can give 50 milligrams every 30 minutes. Make sure your maximum dose should not, your total dose of 250 and the maximum dose in a day should not exceed 400 milligrams. So for pediatrics, it's not, the safety has not been established in as far as tramadol is concerned. So there's no data supporting the use of tramadol when it comes to pediatrics. Next. So these are non-opioid analgesia. So these come to the concept of multimodal analgesia. So you have acetaminophen, you have gabapentoids, you have ketamine, you have lignocaine, NSAIDs, and serotonin reuptake inhibitors as well. Next, so with paracetamol, this is a drug that has been, it's there. It's a very commonly already available non-opioid drug, which can be used for both mild and moderate pain. Also it's used for treatment of fever, if we all agree on that. So this usually used together with opioid when you use it for managing of severe pain as the concept of multimodal analgesia. The issue with paracetamol has a safety profile and it does not possess the side effect as those of opioid, as well as the side effect of NSAIDs, which we are going to see later. But the issue that it has been associated with paracetamol is liver injury, and the acute liver failure is one of the serious issues that has been reported with patients with using paracetamol. So any patient, you can give paracetamol without worrying about liver issue if you're giving a normal dose, but there are a group of patients which you should be worried and try to do liver profile before giving them. And these are the patients who maybe they have malnutrition, issue of alcoholism. So those chronic alcohol use, then they come admitted in the ICU, malnourished patient in the ICU, patient who are dehydrated, elderly patients. So these are the patients you should be worried about liver issue. But physically fit adult male who is just in the ICU, you can give paracetamol without worrying for liver issues. But there are people who have high risk of potential liver damage. And we all know, I think, the dose of paracetamol is 1 gram 6 hourly for an adult, or you can go up 10 to 15 milligram per kilo for a pediatric group of patients. Yeah, so next. NSAIDs. So NSAIDs, we use them in conjunction with opioid for severe management of pain, but also they can be used for management of moderate and mild pain. The beauty of it doesn't have the opioid side effect of sedation, nausea, vomiting, cardiopulmonary depression. So it has that safety profile of opioid. But the issue now, the NSAIDs come with another issues of bleeding, renal dysfunction, inhibited platelet function, so issue of bleeding, renal injury and stuff like that. So it can have limited use when it comes to ICU patients who are compromised. But for post-op patients who are just admitted in ICU just because of post-op observation and they are hemodynamically unstable with no other issues, so opioid has a role to play on that. So IV ketorolac, I know in our setup is not very available, but this is one that has been widely used and recommended to use for post-op as in terms of analgesia, in terms of NSAID analgesia. However, there are our regular like diclofenac oral preparation for ibuprofen as well. So NSAIDs use them, but bear in mind of those side effects. So adequate assessment of our patients before deciding including any sides in their pain management plan. Yes. So I know I've spoken a lot. So now let's pause a bit and have the case that maybe the audience can try to chip in and tell us a few things. So we have John, he's a 52-year-old male who was sustained a burn injury on the chest and abdomen and has been admitted in ICU for 4 days. And because of the burn, he usually have dress changes every 2 to 3 days. So now, from the audience, I like to hear from you. So if you want to respond, you raise your hand and Mariam will give you a chance to speak. So what do you think can be sources of pain for this burn patient who is admitted in ICU for 4 days? Anyone from the audience, please. So you can raise your hand and Mariam will give you a chance to speak. So maybe I can pick anyone, so people are quiet. So let me try to see if I can pick someone from here. So there's Beatrice. Nkulama. Beatrice, can you tell us what are the possible sources of pain for this patient who sustained burn injury? Just one. How about Atala? Atala?
I think Tafa has the hands up. Someone called Tafa.
Okay,
And
Tafa, Mariam.
Tafa, you should be able to speak now if you unmute your microphone.
Hello, Tafa, can you unmute yourself and then speak? Okay, Tafa, can you speak? I see you are unmuted. How about Leonard Imroso? Can you come up, Leonard Imroso?
We actually have a few people raising their hands that I just unmuted. Vital, I think you can speak now if you're available.
Atala, speak up.
Hello,
Yes,
Hi.
Karibu.
hello, Doc.
Welcome, welcome. We can hear you, go on.
Hello, there seem to be voice issues, I think.
Yeah, we can hear you now. Continue. Okay, so maybe we can continue. So from previous presentation, the first presentation that Dr. Anna did, she pointed out very things that can cause pain in the ICU. So for this patient that has burn injury, so the primary disease can be the source of pain, burn itself. There will be dressing every 2 to 3 days. So dressing can be cause of pain for this patient in ICU. This patient will undergo physiotherapy in order to make sure his limbs are functioning, in order to prevent other contraction, stuff like that. So that could be the source of pain for this patient. There will be bathing in ICU for this patient. So that also is the source of pain. It will be turning for this patient in ICU. So this is also the source of pain. So now we are going to see how we can at least manage pain for this patient in order they are supposed to go for dressing every 2 to 3 days. Next, Mariam. So burn, dressing, physiotherapy. Next. So ketamine has been identified as a very good drug that can be used for procedure analgesia in ICU. It acts on the MDA receptor. So when used together with opioid, can provide a very good analgesia for this procedure. So also ketamine, we have an issue of sickle cell crisis in our patients now. So the sickle cell issue has been coming up. We have seen a lot of patients that present with sickle cell crisis. So this is a very good also drug when you combine with midazolam, can be very good in providing analgesia for this patient. So we have to remember our effect of tachycardia, hallucinations, and delirium that are associated with ketamine. So the analgesia dose, it's 0.5 milligram IV, or you can give 5 to 10 milligram if you are going for IM. There are also oral preparation for ketamine, which for patients that if they're first time, you can give them a 10 to 30 milligram oral preparation for ketamine. There is an issue of magnesium, which can also be used for pain, but we know most of our magnesium we reserve for management of preeclampsia. So this might not be a very common type of drug that we might use in our setup, because our magnesium we usually reserve them for preeclampsia with severe features. So, but magnesium also can be used for management of pain. Next. So another options, we have this alpha-2 agonist. These are They are cool drugs, especially dexmedetomidine. It's a very nice drug, but because of our setup, it's not readily available, but it's a very good drug because it gives you the sedative effect, it gives you the analgesia effect with minimal effect associated with opioid. Also has the issue of quick recovery. You can give it while you can do it while you are able to do neurological examination while you still have a very low dose of dexmedetomidine in your system. So it's a very good drug with minimal effect associated with delirium, which has been reported with morphine and benzodiazepine. So, however, it's not very readily available. So, but that's also something also to note, that dexmedetomidine and clonidine, which are alpha-2 agonists, there are also options in management in pain in ICU, but they are not really readily available in our setup. Next. So we have the adjuvants. Now, the adjuvants, these are the drug which they are not per se analgesia. So they are not called the analgesia. So they are not primarily designed for pain control, but because of their mechanisms of action, they can give you a bit of pain control while you are combining them with other analgesic drugs like opioids. So it's recommended by the Society of Critical Care Medicine to give adjuvants like gabapentoid, carbamazepine, which are antidepressant and anticonvulsant for patients with neuropathic pain. So they're very good when it comes to neuropathic pain, but for skeletal kind of originated of pain, they have no effect. So the anticonvulsant, the carbamazepine, they tend to block certain nerve conduction in the pathway because they act on the sodium channels. You have the antidepressants like your carbamazepine. They tend to block the conduction of nerve, and then you have the antidepressant, which they cause modulation of pain. So they are very good when it comes to treat them for neuropathic pain, the ICU. And neuropathic pain, these are pain originated from nerve injuries. So these are usually burning pain sensation. So the patient will present with burning kind of sensation pain. However, you don't have actual tissue damage that is visible. So you have lesion, but these are lesions which are seen from the nerve injury, like patients who are presenting with shingles. So these are characteristics of neuropathic pain or trigeminal neuralgia. So these are typical neuropathic pain, which patient can benefit if you give them analgesia together with adjuvants like gabapentoids and other antidepressants. So another case. So we have Jane, 52-year-old woman, post-open reduction internal fixation, she's admitted in ICU, and the reason for admission in the ICU is cardiovascular instability. So that's the least reason for admission in the ICU. So how will you manage pain for this patient? So this patient is cardiovascularly unstable, means is maybe hypotensive, bradycardic, on number of inotropic support, then is admitted in the ICU. So we know our opioids, some of them, you have your cardiac depressant, you have your NSAIDs, they're not good because sometimes they have renal issues. Your paracetamol also can be affected if the patient has a liver issues. So how can we manage this patient for pain, for post-op pain? So maybe anyone from the audience can say, like, what do you think we can do for this patient? We know opioids, they might not be good, and your NSAIDs, they're not good. The paracetamol also maybe can have liver issues, which they're not good for this patient as well. Might not be good for this patient.
And if you're unable to speak, you can also put your answer in the Q&A box, but I believe we have someone able to speak, so please go ahead.
Joshua?
Yes, thank you very much for the presentation thus far. Would go through the entire analgesic ladder, given that she has an full procedure. So personally, I'm component of analgesics on board, even though, okay, yes, she's prone to having also some hepatic insult if, say, she's hypotensive, but I would say on board adds some anamine and probably combine it with a doc if setting some opioid sparing properties. So I would go ahead to give her either a and then top up with another dose of ketamine, since we know athletic status, and maybe acet and add the range.
Okay. I've catch a bit of that. So you are breaking up a bit, but I've catch a bit of that. So with this patient, we can use other modalities, but we have another something else that we can add from that, and that's regional block. I think I had a bit of regional block in your while you are speaking up. So maybe you can go to the next slide, Mariam, and see. So another option that can be used is regional anesthesia. So our patient is hemodynamically unstable with all that issues, and then she's post-op and she need adequate pain control. The show was very right. This patient in WHO ladder pale, and there she will have a very severe form of pain. So regional technique is one of the options for management of pain in ICU, but this is very good for patients that are coming as post-op, and this is because before going for op, they will have maybe an epidural already set in, so the analgesia will be top up as they go along. It's become very difficult to use this technique while the patient is already in the ICU, admitted for other reasons. But they are very good when it comes for post-operative management of pain. Now the challenge is so it's very good to minimize the amount of opioid that you're going to give your patient. However, there are challenges, and this comes with issue of position during session. So this patient is in the ICU. You can figure out that patient who Anna showed us from the beginning. How are you going to position that patient to put an epidural? So you can have position insertion difficulties, but if the patient this has been planned before hand that this patient is going for op and post-op, we are planning for regional. So this can be a very good modality for pain management while to minimize the amount of opioid we are giving for this patient. There's issue of coagulopathy and anticoagulation. So we have patients in the ICU, they have DIC, coagulopathy, they have platelet dysfunction, or we have our anticoagulant we give them as prophylaxis for patient of DVT. And some of them, they're given anticoagulant as therapy for patients who have implantable foreign body, like implantable cardiac or pacemaker or stent. So they can have anticoagulation, and if the patient is bleeding tendencies, your regional, they are not good. The issue of sepsis and bacteremia. So the regional technique, they are not completely, they cannot, they have a bit of hypotension. We know these are going to act in your spinal cord. So they are not completely avoiding of cardiopulmonary instability. So you can have hemodynamic instability when you're giving your regional technique as well. So issue of hypovolemia. So hypovolemia, we know you can have vasodilatation secondary to your regional technique, especially when you're targeting your neuraxial block. You can have your hypovolemia, which is not very good because they can going to have vasodilate, hypotension and stuff like that. But as well, local infection. This infection at the site of you are planning to insert your needle for regional technique. So these are the challenges when it comes to regional anesthesia in ICU. But if your post-op patient is very good, you can plan ahead, put them, then put an epidural there, catheter, and then in the ICU, they can just top up the drug as they go along. But these are the things also to be aware when the patient is in ICU with a regional catheter in situ, issues of sepsis, coagulopathy, anticoagulation, and infection at the site where you have put your needle as well, your catheter or your needle as well. Next. So there is an issue of sedation in the ICU. So Anna pointed out that there is an interaction between sedation, agitation, and delirium. But most of healthcare providers, they are prone either to give this patient opioid or to give them sedatives like midazolam and the like, or to give them antipsychotic of haloperidol and stuff like that, thinking the patient is either delirious or agitative, while forgetting that this patient can have pain, and this pain can cause delirium, and this pain can cause agitation as well. So remember, before thinking about giving a sedative drug for purpose of initiating sedation, remember there is a pain component. And with the recommendation is make sure you rule out pain in a patient before thinking about giving sedatives, because the sedatives, you will agree with me, they don't have an analgesic effect. So sedation should not be a substitute for analgesia. We all remember the goal for sedation is to reduce anxiety, to enhance patient cooperation, to allow adequate mechanical ventilation, to provide the amnestic state, and then to improve endotracheal tolerance. But that, if there is pain, pain should be treated first and then think about sedation. And with sedation, we know how we can assess our sedation with our Richmond sedation score and stuff like that. So always remember, don't run to sedation. So assess pain first. If there is pain, treat pain. That could be the cause of agitation. That could be the cause of delirium. If there is no pain, now you can shift to give sedation in ICU. So it's common practice when the patient start complaining, either we give them a midazolam or we find a haloperidol there, we give him, and then without considering that agitation or that delirium could be the cause of pain. So we have discussed all the medications. We have treated pain for this patient. Will that be the end of it? The answer is no. Remember to reassess your patient every time after you are giving intervention. And reassessment, it prevents you from to undertreat your patient or to overtreat your patient. So remember to reevaluate your patient every time, hourly, in order to ensure the therapeutic intervention. And we should be proactive while we are treating pain. And when the assessment, if you do an assessment, the pain management is inadequate, don't tell your patient this is not time for your medication. You should wait for 6 hours in order to get another dose, maybe of paracetamol, or you should wait for another 1 hour in order to give you a morphine dose. When the patient is complaining of pain and the management of pain is inadequate, make sure you titrate your medication to make sure the patient is getting adequate pain. So remember, your multimodal analgesic management of opioids, less of opioid, other non-opioid drug, adjuvants, plus or minus regional techniques. And this can be nurse directed, or it can be other patient control. But in our setting, nurses, healthcare providers should be proactive, reassess and manage the pain. Next. So with opioids, they're usually side effects. We all agree, opioids, they come with a lot of side effects. And this in terms of nausea, vomiting, constipation, pruritus, sedation, and adverse, even respiratory depletion. So if you have these issues, remember, you can try to adjust the dose, means going down on your dose. You can try to give what is called opioid rotation, means give another option for management of pain, and then you can give opioid in the next cycle of analgesia. And then you can do symptomatic management. If the patient is have nausea and vomiting, we have antiemetics medication, we have prokinetics, we can use like metoclopramide. Constipation, we can use stool softener, or you can have laxative. For pruritus, most of the time it's self-limiting. It's not cannot lead. Sometimes it can go for a full allergic reaction, but most of the time it's a self-limiting. But there's an option of giving your antihistamines. For cognitive adverse effect like delirium and cognitive impairment, you have your antipsychotics you can use. For respiratory depression, some of the patients, if they are already extubated, these are the patients that may benefit from giving supplemental oxygen or non-invasive ventilation techniques if they are applicable for this patient. So these are the issues that we should know that they can come up with opioid, which is we most highly use in ICU patient. So we should be watchful of these complications and how we can manage them. Next. So what are the challenges? Challenges in ICU. So Anna came out very clear, like most of the patients in the ICU, they are undertreated for many reasons. The pain is undertreated for many reasons. First is patient issues. Patient issues come in terms, Anna said, like, in order for you to manage pain, you should be able to assess pain for this patient. Now, how easy is it to assess pain for patient who are admitted in ICU? So there can be some challenges, especially when there is no a systematic way of assessing this patient in ICU. Because some of the patients, they can be delirious, some of the patients, they're unconscious, intubated, some of the patients, they are sedated already, so it can be challenging in assessing pain. Patients, some of the patients, they have multiple issues that make pain perception more severe, like polytrauma patient, burn patient, those kind of patients. Their bioavailability, the drug elimination is also a problem. So there are issues about patients. So sometimes we can fear prescribing some kind of medication to them. The issue of drugs. Some of the drugs, they have effects like cardiopulmonary depression. Some of the drugs, they cause bleeding like NSAIDs, platelet dysfunction. Sometimes the drugs, even themselves, they are not readily available. We discussed about remifentanil. It's a very good drug, but we don't have in our setup. We talk about ketorolac, very good NSAID to use, but it's not available in our setup. You have healthcare workers issues. Now comes the issue of proactive. How are you proactive in managing, assessing, and recognize, assessing, and treat patients? So in ICU. So this is also a challenge. Some of the healthcare providers, they are not very proactive when it comes in assessing and managing pain. So the issues of like clockwise, like if the drug is supposed to be prescribed at 2 p.m., so everyone will get analgesia at 2 p.m., regardless if in between the patient has breakthrough pain and stuff like that. So there's the issue of healthcare. And then the system issues, lack of guidelines for management of pain in our settings, lack of structured pain assessment tools, even the system support itself. When we're talking about remifentanil, when you talk about the dexmedetomidine, it's issue of system support. So the issue of also system. So these also, there are challenges when it comes in the management of pain in ICU. Next. So these are some that we think we can recommend. I know after listening to this presentation, the participant, they can have more recommendations on how to improve management of patient in ICU, but having hospital pain team is something that is very good. Like you have pain specialists, like Dr. Ndebea, he's a pain specialist. So having people like that on board while managing patient in ICU is something very good that they can help a lot in ideas. Alternative therapy for pain management. So we should think outside the box. We have talked a lot of things there. So if one thing does not work for you in your setup or does not work for you, depending on the patient you are having, you must have alternative option for pain management. The Society of Critical Care Medicine, they also incorporated the issues of non-pharmacological pain management options like music, massage, cold therapy, relaxation techniques, and stuff like that. So there are other alternatives for pain management, not only opioid. So you can have opioid, you can have non-opioid, you can have adjuvant, regional, and non-pharmacological. Regular reassessment of our patient. It's very important. That's why in ICU, there's a concept of 1-to-1 ratio. One patient, one nurse. Like when the nurse is chatting for vitals, also should chat for how the pain assessment for his or her patient in an hourly basis. Issue of having guidelines. There are guidelines available out there for using and protocols for pain management, especially in ICU, like the Society of Critical Care Medicine. They have a published guideline for pain management, agitation, delirium, and sleep deprivation and prevention. So these are the guidelines that we can look at them and see what works for us and then adapt. And then we can also try to team of expertise, and then we can sit down and try to make what works in our setup in Tanzania, in Zambia, or elsewhere. Those who are in Western world, like in Canada and stuff like that, they have a luxury of having everything that they need at their disposal. The issue of clinical pathways, like if the patient is admitted in the ICU, who will take care of this patient? And if it's coming from ICU, maybe it's going for the ED, the OR, how the process is going about. Issue of having checklists, if the patient has been assessed for pain, what medication has been prescribed, is this medication has been prescribed, and how is the assessment now? And then in having daily goals. These are the goals for management of our patient as far as pain is concerned. So with that being said, so we know that patients in ICU, they are at higher risk of having pain, even when they are at rest. So there's issue of anxiety, delirium, sleep deprivation. These are the factors that have associated with increased sensitivity to pain. So the pain threshold for this patient can go down. Organ dysfunction will decrease the potency of analgesia. This is because of issue of bioavailability, the regional perfusion, as well as this, if you have compromised the system, you have increased the risk of toxicity and drug accumulation. Pain assessment is an essential factor in adequate management of pain. You have different pain scale, numerical, visual, you have behavioral, you have critical care tool. All this can be used for different group of people. So we have commonly used opioid, but the more emphasis is toward the multimodal analgesia. And even the recommendation, it should be used with the lowest possible, the lowest adequate dose for opioid. So usually start with the low dose. When the pain is already controlled, there's no need of going to high up. So the lowest possible effective dose for opioid, and then multimodal. Individualized patient care for this, for our patient. All patients are different, have physically fit post-op patient, have septic patient with multi-organ dysfunction. And the provision of analgesia is often compromised by circumstances that may underlies by our underlying pathology. So the patient, their difference, that's how comes the issue of individualization. With that being said, thank you very much. We'll turn this to Dr. Ndebea, our moderator, to continue with the rest of the presentation. And that's our references that we've used. So Dr. Sweetbat, back to you. Thank you very much.
Thank you very much, and thank you very much once again, Dr. Anna and Saleh, for such a wonderful highlight of an important topic, pain management in ICU. So, ladies and gentlemen, with us in this webinar this evening, we have Dr. Papicho and Dr. Ndaba as the panelists, but also we have Magdalena from Gladian, who will also be given a task to speak on behalf of the company later on. So I welcome questions from the participant. You can either raise hand and send and maybe be given permission to talk, or you can send a question in the Q&A area. So welcome, please. If you have any question, if you have any comment, addition, the floor is yours. As we are waiting for someone to raise hand and speak, there's a question in the chat box. Anasia Knight Daniel, I think this is from Uganda. The question is, how can anxiety make pain worse? And is it possible for one to be addicted to pain management medication after recovery? Then what should I do to prevent that? Daniela, ICU nurse in Arua, Uganda. Ndaba or Papicho, anyone can feel free to respond. Or
Hello, Dr. Sweetbat.
Hi.
Yeah, I think let me start, and then Dr. Papicho can add, as well as other pain specialists in on the call. So anxiety, really, I think, like was mentioned earlier in the presentation, it can complicate the expression of pain, as well as perception and assessment. So anxiety is just one of the parameters within the process of assessment that should be looked at, and then together with other parameters should be used to assess the severity and also whether there's a presence of pain or not. So an anxious patient can really sometimes be difficult to assess whether the anxiety is due to pain or anxiety is due to several other causes. That's why it is very, very important that as we assess pain, we look at the different modalities or tools that we can use to make sure that we are accurate in our assessment. And the tools, some of them have actually been discussed here, and others can be found, I think, in different literatures that is available. So to be more accurate, it's important that we look at other parameters, as well as look at whether the patient is the psychological state, whether they are anxious, they can verbalize, are they able to give signs, are they cooperative? Yeah, then together with that, I think we'll be more accurate in assessing pain in our patients. Yeah, I don't know, Dr. Perpetual, if he has anything to add, or Dr. Sweetbet. And then there's a hand from Elias Charles. I think he'll be given a chance to speak as well. Over to you, Dr. Sweetbet.
Thank you, Ndaba. I think that's well said. The most important thing is that we have emphasized in the assessing pain. So as you said, we are with an anxiety. You might not assess pain adequate, which will lead to inadequate pain management. So basically, I have nothing to add.
Right.
Maybe
I can
areas.
just add up something, Dr. Sweetbird.
Okay.
And when patient is so anxious like that, agitated, and all those things put together, often it might lead you to go to overdose because you wouldn't know, was it anxiety, was it pain, and then you are fighting for anxiety, you are giving more drugs, and then you give more than what patient should receive. So it's better to really go for the cause of that pain and then sort out the added part of the anxiety that comes along. Thank you.
Areas, you can unmute yourself and go on. Areas, Charles. I think we have only 3 minutes. Areas, Charles. Yeah, I think he has issue with the audio. Elias, can you hear me?
Yeah, so Dr. Sweetbet, I think whilst we are waiting for Elias to sort out the audio issue, I just had a quick additional comment. I think this was mentioned by the presenters regarding pain management, especially in low resource settings. We know that studies have so far revealed that generally pain is something that is underrated and undermanaged, like our presenter put it at the beginning. In as much as we know that the biggest issue and challenge we have is access to pain medication, but studies really have revealed that lack of knowledge, as well as attitude towards pain, also come out very prominent as factors that interfere with pain management. It has been found that inadequate knowledge in most of us as healthcare workers really has led to insufficient pain management, also lack of knowledge of the variety of drugs that you can use, pain management alternatives that you can use, and that has led to us not being able to manage pain adequately. Other than that, I think it's just generally the attitude and also cultural, factors that interfere with the perception of pain. But I think all in all, for us who are privileged to have this information about pain, the diversity of drugs, objective assessment, and also since we realize that pain management is very, very important, I think it's our duty and task to make sure that we extend the knowledge to those clinical areas where we think that pain is undermanaged. I say so because, people from the anesthesia side of things, critical care side of things, I think they are more privileged to have a bit of information about things like opioids, the diversity around NSAIDs, because we use them more routinely. And so we should be able to extend that, the knowledge, and also share some of this, literature to other clinical areas, the wards, ER, and other setups. So I just wanted to quickly add that comment, the moderator, sir. Thank you.
Thank you very much, Ndaba. I also wanted Dr. Elias Dati to share the experience. I think he's in the, Dr. Dat, Professor Dat. If you are available, please, can you please share experience with us? Looks like it's no longer that. So at this juncture, it's almost time. May I welcome Magdalena for the word, and then maybe we'll call it a day from here. Magdalena, karibu sana.
Thank you very much, Dr. Sweetbat. Thank you very much, our panelists. Thank you for our presenters, Dr. Mrutu and Dr. Anna. We do thank you for taking time to prepare all this for our participants from all over the continent. We do really appreciate on the issue of pain management. As Gradient Health Systems, our focus is mainly to create products and also technology that will assist anesthesiologists and also in critical care space in terms of managing all this that you have learned today. So you could just visit our website to find out what we do. Our projects, our machines are actually embedded together with training and continuous support, and also continuous service and technical support. My internet is not quite good, it keeps going on and off, so I will just end it there. And I want to thank the participants for staying this long and keeping the number stable. And thank and sorry for those who had technical hits. We all understand some of the challenges that we face with internet in us. So thank you.
Thank you, Magdalena. And once again, thank you everyone for setting up time and attending this webinar. At this time, we end up here, and I hope to see you again for the next one. Please visit our website, visit our chat box, visit our social media, and we will let you know once we announce for the next one. Asanteni sana.
Thank you so much. Bye-bye.